Pressure is normal. A repeat CXR performed at over 24 hours after the trauma is not normal. He is re-imaged during his intensive care unit, ICU, stay and at one point undergoes a computed tomography pulmonary angiography, CTPA, which is negative for pulmonary embolism, PE. The clinical team suspect acute respiratory distress syndrome, ARDS. Which of the following radiographic features is inconsistent with this diagnosis? A bronchial dilatation on computed tomography, CT. B. Bilateral heterogeneous airspace opacities. C. Diffuse reticular changes. D. Pneumothorax. E. Bilateral pleural effusions. 2. A previously well 42-year-old man is admitted with acute left-sided pleuritic chest pain. His SoundTwo is recorded as 92%. D. Dimer assay is elevated. His mother had died suddenly at the age of 58 years. He is NCE of left heart failure, and thus the presence of a pleural effusion casts doubt on the diagnosis. The appearance of ARDS can otherwise mimic pulmonary edema. Bronchial dilatation is frequently seen on CT. The alveolar changes are heterogeneous, showing a density gradient in both the craniocaudal and anteroposterior directions. The dorsal forward/dependent and lower lobes are denser than the ventral forward/non-dependent and upper lobes. Radiographic changes tend to be absent for the first 24 hours, with the exception of direct lung injury, then increase to remain static for days or weeks, and then begin to resolve. Pneumothorax can occur secondary to ventilation. Reticular changes, with a predilection for non-dependent lung, may be secondary to the underlying process or to barotrauma, seen in 85% of survivors in one study. The mortality of ARDS is approximately 50%. DACISR acute respiratory distress syndrome, imaging of the injured lung. Clinical Radiology 2002, 57, 817. 2e. No further investigation is further investigated via CTPA, which is negative for PE. Based on his presenting symptoms, the referring consultant continues to be concerned that the patient has a PE. What advice do you offer regarding this patient's management? A. Refer for V/Q scanning. B. Refer for catheter pulmonary angiography. C. Commence anticoagulation for 3 months given clinical suspicion. D. Commence anticoagulation for 6 months given clinical suspicion. E. No further investigation or anticoagulation required. F. Repeat CTPA. Question: investigation or anticoagulation? Anticoagulation required. In the setting of a low-probability clinical assessment and positive D-dimer assay, a negative CTPA has a negative predictive value of 96% and further investigation and treatment are therefore not warranted. A repeat CTPA may be indicated if the images are of poor quality. The prospective investigation of pulmonary embolism diagnosis, PIOPT. 2 investigators recommend that in the setting of a high pretest probability, a negative CTPA should be followed with either venous ultrasound or Mr. venography. Stein PD, Woodard Park, Week JG, Wakefi ELDTW, TAPSUN VF, Sossman HD et al. Diagnostic Pathways in Acute Pulmonary Embolism, recommend. Two cardiothoracic and vascular questions. 3. A 45-year-old male smoker has a 6-month history of gradually increasing shortness of breath and cough. CXR shows a mild increase in interstitial markings in the mid and upper zones. An high-resolution CT, HRCT, of chest is requested for clarify cation, and this demonstrates ill-defined centrilobular ground glass nodules, more pronounced in the mid and upper zones. There is no traction bronchiectasis or honeycombing. What is the most likely diagnosis? A desquamative interstitial pneumonia, DIP. B. Usual interstitial pneumonia, UIP. C. Respiratory bronchiolitis interstitial lung disease, ABILD. D. Nonspecific C. Interstitial pneumonia, NSIP. Recommendations of the PIAP2 investigators. Radiology 2007, 242, 1521. 3C. Respiratory bronchiolitis. Bronchiolitis interstitial lung disease, ABILD. ABILD is a disease of smokers and the centrilobular nodules refill CT chronic inflammation in the respiratory bronchioles. GGO may occur and is typically multifocal and upper lobe predominant. Reticulation is uncommon and fibrosis is not a typical feature. The typical features of UIP are reticulation, honeycombing, and traction bronchiectasis, with a basal and subpleural predominance. NSIP has overlapping features with UIP, but GGO is more common and honeycombing less common. There is a similar basal and subpleural predominance on HRCT. DIP is a rare disease and, like ABILD, associated with smoking. The cardinal feature is GGO, with a basal and peripheral predominance. Sometimes small cystic areas can be seen within the areas of GGO. Progression to fibrosis / honeycombing is rare. A desquamative interstitial pneumonia, DIP. E. Cryptogenic organizing pneumonia, COP. For a 25-year-old with a history of cystic fibrosis presents with massive hemoptysis. Bronchial artery, basal and peripheral predominance. Predominance. Sometimes small cystic areas can be seen within the areas of GGO. Progression to fibrosis / honeycombing is rare. Cardiothoracic and vascular answers 25. COP was formerly known as bronchiolitis obliterans organizing pneumonia, BOOP. The main finding on HRCT is consolidation, which is usually multifocal and bilateral. It typically has a lower zone and peripheral predominance, but can affect any lobe. Dilated airways are often seen on HRCT with air bronchograms mimicking acute pneumonia. There may also be GGO and reticulation, but lung volumes are usually maintained. Dixon S. and Beenamore R. The idiopathic interstitial pneumonias, understanding key radiological features. Artery embolization is requested. Which of the following statements regarding bronchial artery embolization is false? A descending thoracic aortogram is performed prior to selective bronchial angiography. B. Bronchial angiography is performed with manual injection of contrast medium. C. The abnormal bronchial artery is embolized at its origin. D. Polyvinyl alcohol particles, diameter of 350-500 m, may be used as the embolic material. E. Chest pain is the most common complication. 5. Dixon S. and Beenamore R. The idiopathic interstitial pneumonias, understanding key radiological features. Clinical Radiology 2010, 65, 823831. 4C. The abnormal bronchial artery is embolized at its origin. Bronchial artery embolization, BAE, is an established procedure in the management of massive hemoptysis. Knowledge of the bronchial artery anatomy and its variations is essential in carrying out the procedure safely. A preliminary descending thoracic aortogram is performed to identify the number and site of origin of the bronchial arteries. Abnormal bronchial arteries are visualized on the preliminary thoracic aortogram in the majority of affected patients. Selective bronchial angiography is performed with manual injection of contrast. Selective bronchial artery catheterization and safe positioning distal to the origin of spinal cord branches is essential to avoid spinal cord ischemia/infarction. Polyvinyl alcohol particles, 350-500 m diameter, are the most frequently used embolic agent. Smaller particles can freely flow out via the intrapulmonary shunts, causing pulmonary or systemic infarcts. Chest pain is the most common complication. 94-91%. Other complications include dysphagia, due to embolization of esophageal branches. Dissection of the bronchial artery or aorta, usually self-limited, and spinal cord ischemia. Yoon W., Kim J.K., Kim Ye, Chung T.W., and Kang H.K. Bronchial and non-bronchial. A 73-year-old patient is involved in a road traffic accident, RTA, and sustains a head injury. He is intubated at the scene due to a low Glasgow Coma Scale, GCS. The patient is transferred for a CT chest as he is hypoxic. On reviewing the CT scan, you note widespread emphysema, consistent with the history of smoking. He has a narrowing of the trachea, immediately inferior to the distal margin of the endotracheal, ET, tube. This narrowing is caused by an endoluminal mass associated with a circumferential area of soft tissue that extends into the paratracheal space. There is no pneumomediastinum and no other lung injury is seen. What is the most likely cause? A post-intubation stenosis. B. Tracheal papilloma. C. Non-small cell lung cancer. D. Adenoid cystic carcinoma. E. Squamous cell carcinoma. Cardiothoracic and vascular questions 3. 6. A patient is admitted with a comminuted femoral fracture. Initially he is quite well, but goes to theatre for internal fixation of the fracture. His clinical condition deteriorates after 24 hours and he develops fever, hypoxia, and confusion. The clinical team have noted a rash and at the same time as requesting a CT chest, request a CT brain, meningitis secondary to epidural. The CT chest reveals widespread peripheral areas of ground glass opacified cation, GGO, and airspace consolidation. There are no septal lines or pleural effusions. A follow-up radiograph 10 days later reveals complete resolution. What is the Embolization for life-threatening hemoptysis, a comprehensive review. Radiographics 2002, 22, 1395 1409. 5e. Squamous cell carcinoma. Tracheal malignancies make up 1–2% of all adult intrathoracic tumors and as such are uncommon. Malignant lesions make up 90% of all tracheal malignancies. Of these, squamous cell carcinomas are the most common, presenting in elderly patients with a history of smoking. Adenoid cystic carcinoma is the next most common, presenting in a younger age group and associated with a better prognosis. Benign lesions account for less than 10%. Non-small cell lung cancer, NSCLC, would be the leading differential diagnosis if this lesion was found endobronchially, but not in the trachea. NSCLC can cause tracheal narrowing, but as an extrinsic lesion. The history is too brief for post-intubation stenosis to be considered and this is not associated with a soft tissue mass. Maromi, Goodman P., and McAdams